Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc.
Hi, welcome. My name is Jorge Fortune, and I'm a retina specialist practicing at the Bascom Palmer Eye Institute out of Palm Beach Gardens, Florida. And welcome to this program titled the Retina Futures Forum, Focus in RVO. I'm joined today by my friend and colleague, Priya Vakaria. Priya, do you like to introduce yourself to our audience?
Yeah, great to be here with you, Jorge. My name is Priya Vakaria. I am a retina specialist. I work at Retina Vitreous Associates of Florida in Tampa, Florida.
Fantastic, Priya. So, just a quick outline before we get started with the program. This is part of a series of programs looking at the evolution of care in eye disease. And obviously, as the title implies, ours is about RVO. But really, what we hope to present is an overview first of the evolving evidence of the real world burden that our patients with RVO face, and really how our practices have changed over the years with the evolution of pharmacotherapy and other treatment modalities and how we think about the disease. And so Priya will go over some of the latest evidence to support uh, the care that we provide our patients. And then we'll jump into some case-based discussions so that we can highlight and showcase how that care comes into practice in our everyday clinics. Uh, we know that retina care has a legacy of innovation, and in the practice of RVO, we've really come a long way in the last few decades, starting off with laser-based treatment and then evolving to the use of pharmacotherapy, first with steroids and then with anti-VEGF agents. And really, because of the recurrent nature of this disease and because we treat patients that have real world circumstances and the high treatment burden, we've really evolved from shorter acting agents to longer acting agents. By that meaning agents that provide the same amount of clinical relief while being allowed to be dosed much less frequently. And so, again, this program is a great opportunity to reflect on where we were and really more where we are now, thankfully, with the cutting edge of intravitreal pharmacotherapy with anti VEGF agents. And so, without further ado, I'll turn it over to Priya so she can go over the foundations and understanding evidence and real world burden of RVO. Priya?
Thank you, Jorge. All right, so let's talk about the management of vein occlusion over time. So, really, laser and steroids used to be mainstays for vein occlusion care, which is really remarkable to think about because, that was even before my time. It's just the change in the way that we treat vein occlusion has been really dramatic. And the advent of anti-VEGF therapies have really changed the way that we manage not only retinal vein occlusion, but all retinal vascular disease. And the question is, what's next? And obviously, there are therapies that are coming up in the future that are really exciting. But again, we're going to focus on what we used to treat patients with versus what we treat them with now. Again, historically, we used to treat them with steroids and grid and focal photocoagulation. Honestly, I don't think I've ever done a grid and focal photocoagulation for vein occlusion ever. Jorge, did you used to do these?
I didn't like where you said before my time because this is actually right smack in the middle of my time, but we won't dwell too much on that.
It's amazing about how far we've come because now we have these really great therapies. We started with what I like to call first generation agents, and this included ranibizumab, bevacizumab, and aflibercept 2 milligram. And you can see here the trials that resulted in approval for these, and these have been again really revolutionary for how we've treated retinal vascular disease and retinal vascular occlusion. But then we have what I like to call second generation agents. The first is faricimab, which was approved based on the Balaton and Camino trials. And this resulted in approval for faricimab for the treatment of both branch and central retinal vein occlusion. And in both of these trials, patients had an improvement of visual acuity and an improvement of CST as compared to an aflibercept 2 milligram control, and had longer intervals of treatment with about 60% of patients getting out to 12 or 16 weeks in Balaton, and about 45 to 50% getting extended out to 12 or 16 weeks in Camino. And again, safety with faricimab was similar to the safety profile that we're used to seeing in the other trials, and very comparable to aflibercept 2 milligram, with the most common adverse events being, the injection side effects, dry eye, subconjunctival hemorrhage, but also rare cases of inflammation. Again, very similar to the aflibercept control arm. The other second generation agent is the aflibercept 8 milligram, and this was approved based on the Quasar study design. And in this trial, it was very similar in that patients were treated compared to an aflibercept 2 milligram control and had improvement of both visual acuity and CST, that was not inferior to aflibercept 2 milligram. And again, in this, patients had extended dosing intervals. And Jorge, this is what it's really about. Patients don't want to come to our office, as awesome as we are. They would rather be in Tahiti. And these second generation agents, the trials show that patients are able to extend out longer. In Quasar, patients were able to extend out in about 94% of patients out to greater than 8 weeks. And again, some of the numbers here of extension, don't hang your hat on those because these trials were very different. They were structured very different. But the takeaway point is that we have these second generation agents. They allow for similar non-inferior visual acuity results and CST results with extended dosing intervals. And of course, I would be remiss if I didn't talk about the safety of aflibercept 8 milligrams, which is consistent with the established safety profile of 2 milligram and 8 milligram in the other trials. No cases of occlusive retinal vasculitis. So, Jorge, how are you treating patients in clinic? Can you tell me about a newly diagnosed patient that you might have seen and the difference between how you've treated them before versus now that second generation agents are available?
Yeah, Priya, I reached back into my timeline and found a patient, reflecting on this program, found a patient that I treated before these second generation agents were available. And so this is a case I found in my case files going back to 2013. You can see we actually had spectral domain OCT. It's not that far back. It's not time domain OCT. But here you see a 72-year-old professor of engineering. It was very difficult for him to make it down to South Florida. He wanted to get care with us, and we have a classic presentation of an RVO here with intraretinal hemorrhages, and you can see there on the right macular edema. For our audience, Priya, newly diagnosed RVO, this is a 72-year-old gentleman with risk factors, right? Diabetes or hyperglycemia. Um, but what scenario before initiating treatment would you do anything further? We know that retinal vascular disease can be tied to systemic disease. And so what's the patient scenario where you would consider doing a workup, and what would that be?
That's a great question, and I think it's something we commonly overlook in clinic. I think that this patient's a pretty standard vein occlusion patient. He's 72, but he doesn't have hypertension, which is a little strange to me. So I would probably, for an older patient that doesn't have hypertension, recommend that they get a hypertensive workup. Perhaps look into sleep apnea because we do know there's some association with sleep apnea and nocturnal hypertension. But if this were a younger patient, I would, in their 30s, early 40s, I would definitely initiate a hypercoagulable workup, looking to see if they have something underlying causing a vein occlusion, or if they're atypical, right? Sometimes you can get vein occlusions that are atypical that might suggest more of a leukemic process or inflammatory process. So anything atypical does require a workup. I'll consider fluorescein angiography or a systemic blood workup. But this looks like a pretty standard vein occlusion that's just related to, again,
Yeah.
presumable hypertension, or age.
Yeah, I think that's incredibly well stated. I think we all kind of just have a gestalt idea. We see a patient, we say this seems about right, right? Typical patient, right? Older, underlying risk factors, but if anything doesn't quite fit, whether they're younger or, as you said, have an atypical presentation, then I think it behooves us to, either refer them to their PCP for a systemic workup, or undertake it ourselves. So, you know, this is farther along the timeline of grid laser, right? Which was, in the case of branch retinal vein occlusion, established by the BVOS study, right? That found that grid laser was beneficial in patients that had vision of 20/40 or better. And steroids had already been approved, but as you pointed out, ranibizumab along this time had been approved. And so we started with anti-VEGF therapy. And you can see there a very clear pattern, which is that anytime we made it past 4 weeks, right? The first time we tried to treat and then extend to 6. The second time we tried to treat and then extend to 5. So this is a pretty early on recalcitrant case as far as extension is concerned, with the edema just popping right back up. And so at that time, really my option for longer duration treatment, and by the way, still remains an option now, would have been to treat with steroids, right? We know that the SCORE trials were the first to show that intravitreal triamcinolone in that case was effective, but we know that we have trials that show that now intravitreal dexamethasone implants, which are approved for this condition, can give us longer lasting treatment. But had this patient been treated today's day and age, I think that certainly switching from what we would consider a first generation to a second generation, whether that be faricimab, or 8 milligram aflibercept, would be an option. And I think you hit the nail on the head, Priya. I tell all my patients the goal of this is to get you better with the fewest number of injections, right? And so the goal is really to extend these patients. It's important, for our audience to know, and they may understand this already, but I do explain this to patients often, is that these injections are not really a treatment for the condition. They're a treatment for the secondary effect of the condition. And so these are treatments for the edema, not treatments for the vein occlusion. And so a lot of these patients will have recurrent edema that needs to have continued treatment. So it behooves us to find the longer and longest acting treatment. So now that we got out of the way back machine, Priya, when I was using ranibizumab and you were, still cheering on your college football team, uh, why don't we, switch to a different type of case, right? So we talked about a first presentation treatment naive patient. Now we have a patient that has been on treatment for a long time, and they've gotten to know you. They know all your staff. They ask you about your kids because you've been treating them now for a really long time, and perhaps they're maybe starting to get a little bit of what we call treatment fatigue. And so maybe you can talk to us about a case like that.
Yeah, absolutely. And I just want to clarify, I wasn't cheering on my college football team that time. I was cheering on my high school football team.
I
But
know I gotta do myself some favors here.
all right, perfect. So let's talk about a patient who, I saw before we had, again, second generation anti VEGF. This is a 47-year-old male who came in with sudden loss of vision. And the really unique thing about vein occlusion patients is they know when they lost vision because they go from good to suddenly bad. And this patient was relatively healthy, seasonal allergies, not smoking, no medications. This is a patient, again, who I would definitely consider a workup on because it doesn't really have any risk factors to have a vein occlusion and is relatively young. And this is the presentation. And I will say I was pretty surprised by the severity of vision loss. I mean, you can see here there's macular edema, there's vein occlusion, and the patient's vision was down to 6/200. There was also some macular pallor, and weirdly enough, this patient had a focal cataract. Fluorescein angiography showed perfusion. There's some blockage here from a focal cataract, but we do have macular leakage as well in the fluorescein angiography, which isn't well evidenced on the fluorescein because of the focal cataract. But in general, this patient almost seems to have this borderline ischemic presentation. So again, I advised a check of blood pressure, hypercoagulable workup, and sleep study, and lo and behold, the patient did have undiagnosed mild hypertension. But let's go back to the OCT and to the patient's presentation. Again, has pretty significant edema. I ended up giving a sample of aflibercept 2 milligram just to get this patient started on getting the vision better. Again, he's pretty young, he's working. He comes back in 4 weeks later and his vision's 20/160. So again, we're making progress. We have improvement of the overall edema pattern. But now I have to switch back to bevacizumab because step therapy is in place. And so we have to use our our compounded medication, our compounded or repackaged anti-VEGF. And I'm doing this every 4 weeks, but the vision just isn't getting better. And it's strange because, again, the edema is getting better, but the vision just isn't getting better. Again, we still have that focal cataract, but the patient asks if they can tier back to the aflibercept 2 milligram, and I say, absolutely. We've gone through step therapy now. And the aflibercept 2 milligram does improve the patient's vision. Again, I guess more strikingly, at least improves the patient's edema quite sufficiently enough that now we can try to eventually treat and extend this patient. Stayed at 4 weeks for a while, got the vision better to 2032, and then started extensions by 2-week intervals. And we continued this for a while and kept the patient on 10 weeks. And that's about where we left him because at 12 weeks, you can see started to get some increased edema. And so, again, this patient stayed on 10 weeks for a long time. I think it was about a year or two. And then we got approval of aflibercept 8 milligram. And again, this patient wanted to get longer between injections, was overall doing well, but wanted to get longer durations, have free him from coming to our clinic, switched him over to aflibercept 8 milligram, and we were able to get an additional 4 weeks of extension out of this, which may not be that much on paper, but is really meaningful to this patient. That's a whole extra month. That went from 4 injections a year to 3 injections a year. So he's thrilled. His vision's 2032. Edema is well controlled and is on now the second generation agent at 16 weeks. And, it just goes, I think back to this patient about if I could have treated with aflibercept 8 milligram from the beginning, how many injections would I have, quote unquote, saved this patient? Um, and certainly we can't go back in time and change that. But going forward now, he's on this more durable agent. Jorge, what's your threshold for switching patients from aflibercept 2 milligram to 8 milligram or from a first generation to second
Yeah.
generation? What interval is the interval that you're comfortable with leaving them on a first generation agent versus switching them to the second generation agent?
You know, that's a really good question, and I don't want to sound like a Hallmark card or a Lifetime movie here, but every patient is unique, right? Every patient is special, and I think that you know, we're both in the education business, and we both talk to younger physicians, and when my fellows come into my clinic, they'll say, why is this patient at this interval, or why is this patient at that interval, and they don't know the patient, right? But much like this gentleman who you'd been seeing for 2 years, we've been seeing some of our patients for a decade. We know about their lives, right? And we know what is good for them, not just on OCT or vision wise, right? But what's good for their life. And just to point out, this is a 47-year-old patient, right? Middle age, obviously working age. Potentially has younger children. That's a lot of other sort of burdens and other things that come into play, right? So 10 weeks, right, on a first generation agent may be absolutely perfect for your retired 79 or 80-year-old patient who really just has to make it to mahjong uh, every month or so. But to this person, that extension from 10 to 16 weeks is significant. So to answer your question, it varies from patient to patient. Now, what I will say is interesting about this case, Priya, is that you could have kept slogging away with bevacizumab or even another agent, but you noticed that you still had a nice response in edema, but you had residual edema there, and you paid attention to the vision, and you said, hey, this vision isn't really quite getting better. So that prompted a switch. So I think it has to do with response on OCT, response in vision, but then that interval really is predicated by the patient's tolerance to being on a certain interval or needing to be extended because of their life circumstances. So
Yeah, I mean, this patient was thrilled. And, I don't know if I believe the change in vision. It was very dramatic from like 2160 to or whatever it was, pretty significant poor vision to all of a sudden great vision after a single aflibercept 2 milligram. But regardless, anatomically, the patient did well. And regardless, the vision did really well on switching agents. And then we had great anatomic control with the second generation durable agent. So, Jorge, I want to kick it back to you.
I'd like to talk a little bit about a patient who not only just can't be extended, but you know doesn't really show up to their appointments on time. And listen, as somebody who's a patient myself, and they say physicians make the worst patients, you can't get too upset when patients don't come in at precisely the schedule you'd want. We have this issue with so many retinal vascular diseases, whether they be, neovascular AMD, whether they be diabetic macular edema. But what's interesting to me, and we can talk a little bit about it, is how sensitive retinal vein occlusion is to treatment intervals. Um, you can, as a physician, see that if they're over by 3 or 4 days, the swelling gets worse. And what's even more remarkable, and Priya, you could probably speak to this, is patients know exactly when their interval is up. And so they'll tell you, yep, it happened, last week on Tuesday. And so it's one of those things where, treatment interval and adherence to treatment intervals is important in every retinal vascular disease, but it seems to be particularly sensitive in patients with RVO, and this is one such patient. So this is a patient who, as many of my patients at my institution, end up coming sort of for a second or a third opinion, and had been treated prior for a branch retinal vein occlusion every 4 to 8 weeks. And you notice that I say every 4 to 8 weeks, and that range is not due to the prior treating physician's choice, who they were doing a wonderful job. It's just the patient's inconsistency. This patient was a combination of things. She was a caretaker for her elderly husband. And on top of that, I think there was a little bit of treatment fatigue or frustration of, why do I need to keep getting these shots? They're not working. And that's where I think the importance of highlighting to patients that these are treatments, not cures, and that our goal here is to keep the edema away while hopefully the body develops collateral circulation. And that if we set that expectation that in one way or another, and we hope it's with longer treatment intervals, we're going to have to keep treating, then you get buy-in from patients. And then, she would say, yeah, the injections work for a few weeks. In her case, you'll see they worked for about 5 weeks, and then they stopped working. And so she was sort of fed up with these injections. And when she presented, her last injection had been 6 weeks prior. And I'd like to point out, you see the OCT map. I think, for our audience, don't ignore the map. The map is sometimes a real easy way to see, where the swelling is coming from. This is a unique case, and it's something that we don't have a lot of time to talk about, but, the audience can look this up. This concept of TEL caps, right? Telangiectatic capillaries. We see these in diabetic macular edema. We certainly see them in RVO. They're these high flow regions that sometimes present early on, or sometimes present after a lot of treatment with anti-VEGF, and they're notoriously sort of difficult to treat. And so the patient had been on bevacizumab, and we started with aflibercept 2 milligrams. And you can see that with aflibercept 2 milligrams every 4 to 5 weeks, the patient does great. And you can see that when we go to 8 weeks, and not again by choice, we go to 8 weeks, we get this sudden swelling. So at this point, again, we're dealing with a patient that has treatment fatigue, that is a little bit doubtful about, what role these injections are playing. And so we switched over to 8 milligrams, and you can see that, at the latest follow-up, we're certainly able to get out to at least 8 weeks, and hopefully even further. But even with just that consistent being able to make it 2 months, she was very happy. And so I think there's a benefit there in these particularly difficult to treat patients that have such short intervals. In her case, particularly because of that TEL cap that was present. We don't have time to talk about it. Laser may be effective. So, bringing the past to the present, laser may be effective for some of these TEL cap patients. But certainly switching over to second generation agent with 8 milligram aflibercept was beneficial. Again, I'd like to highlight that the goal is always to extend the treatment interval. I think it's important to point out that intravitreal dexamethasone implants still play a role. Okay, that's always in our armamentarium for patients that may not be able to be extended. Right, we know that extension to 12 or 16 weeks with faricimab or aflibercept 8 milligrams was not 100%. So we're still going to have some patients that may have an inflammatory component that may may need to have steroids. So please keep that in mind as well.
Jorge, that was an awesome case, and that's such a win for the patient to, just have better disease control on longer intervals, and, I love that. The last case that I wanna highlight is the patient that, despite getting anti-VEGF, maybe doesn't have the best vision. We know that there's 2 types of vein occlusions. There's non-ischemic and ischemic. And sometimes it can be frustrating to treat that patient who's ischemic or turns ischemic. And it can almost feel like you're losing the battle. But I just gonna want to highlight a difficult to treat patient with vein occlusion. And so this is a patient who presented to my clinic initially looking like a pretty standard vein occlusion patient. Had some mild hemorrhages, some mild macular edema, and was 20/40, treatment naive. And again, this was back in the past. I, at this point, started the patient on bevacizumab. And again, you can see scattered hemorrhages here, but nothing out of the ordinary. Vision's 20/40. And then thinking to myself, this patient's probably going to do great on just bevacizumab alone. A lot of these vein occlusion patients do great regardless of the agent that they get. And so again, I initiate bevacizumab and bring the patient back. And the thing I want to highlight here is you're starting to notice a little bit of internal hyperreflectivity, a little bit of interretinal hyperreflectivity there, which is unusual, but I don't think too much of it. Even though the edema got better, the vision got one line worse. And so I say, okay, let me treat again with bevacizumab. And again, now I'm seeing that the retina is actually becoming more atrophic over time and the vision is declining. I'm going to 21/25. And so this unfortunately is a patient who is becoming ischemic. And ischemia limits the vision and there's nothing you can really do to get that back. And so now I'm a little bit anxious to try to do whatever I can to control the disease a little bit more. I give the patient another bevacizumab and try to extend them to 6 weeks just to see if I can get a little bit of longer intervals. And you can see here now the patient has significant edema, vision drops to count fingers. And it's at this point that I decide to switch over to a second generation agent. And the second generation agent that I pick in this case is faricimab. And so I give the patient faricimab. I actually keep them at a 6-week interval because, again, the vision isn't great. I'm trying to help limit treatment burden. Patient comes back 6 weeks later and looks fantastic on faricimab. And the vision did improve from count fingers to 20/160. And so, again, we continue with faricimab on this patient and do a slow treat and extend. Vision's 2200, but we're able to extend this patient out to around 8 weeks. And so, Jorge, I want to kick this back to you because this is a patient who, despite getting anti VEGF treatment, went from 2400 to 2200. And you can just see the difference between their initial OCT, where overall they have, a pretty healthy retina. They have edema, but seem good, to where they ended up, which is with an atrophic retina and ischemia. And, what do you do for these patients? And how do you manage this? Is there how do you counsel the patients in this
Yeah.
situation?
So you've heard me say probably a little too often that I'm big on setting expectations, right? Because disappointment comes from expectations not aligning with reality. And you've heard me in this program say that I always tell patients that this intravitreal pharmacotherapy is really to treat the edema, right? When you see the label for all these medications, it's not for the treatment of retinal vein occlusion. It's for the treatment of macular edema from retinal vein occlusion. And so, what I explain to patients with an analogy is I say, you've got an outflow pipe that's blocked. And two things happen when that outflow pipe is blocked. You can't get the blood out, and so we get swelling, but you can't get fresh blood in either. And that's going to cause damage. And I can only address one of those, which is the swelling, right? But there's going to be some vision loss that's already either happened or may happen because, again, I'm not changing the course of the disease. I'm just trying to bail out water from the macula. And I think your case highlights that exactly because that did have some ischemic characteristics, but likely, you started treating the patient hadn't fully evolved their RVO, right? And we have good evidence to suggest that our treatment doesn't convert non-ischemic to ischemic RVOs. That's just happens somewhere where we can't see it. That patient then went ischemic. So I think just explaining to the patient that we're trying to treat the swelling, that there may be irreversible vision loss from ischemia that could very well happen. I always tell patients, I don't know where you are in the course of the disease. I don't know if you've, you know, completely occluded, if your occlusion is getting better, as some of them do on their own, or if it may get worse, but we're going to treat this swelling. And so I think, you know, you did very well to sort of treat that more acute phase by switching right to a second generation agent. But you know, unfortunately, as you started to note, the vision didn't really get any better from the ischemia. So I think it's just a matter of preparing the patient for the course of the disease.
So, Jorge, I'll ask you a question. For these patients, do you ever start them on aspirin or do anything differently systemically? Because I'll have a lot of patients who either convert to an ischemic vein occlusion or come in with an ischemic vein occlusion, ask if I can do something to open up the blood vessel or improve the perfusion. And I have to explain that these vessels are very small and we can't really access them in an easy way. Um, but should we be starting them on aspirin? And I know that there's really no good evidence for that, but anecdotally, what do you do
You know what
for
I
these
what I
patients?
try to do at that point, and I think this is an example where you have a relatively young patient, if I remember the presentation correctly, and even though they didn't have any hypercoagulability to speak of, et cetera, somebody that I might still say, hey, let's talk to your primary, or let's potentially talk to a hematologist, and say, hey, we've got this scenario, you know, where we converted from a non-ischemic to ischemic. Do you think there'd be any benefit or any harm to doing some mild anticoagulation with something like aspirin, or is there any other things you could look for? You know, my extent is to think about the systemic things. I try not to get too involved in the systemic treatment, but I like to think about it and then refer appropriately to one of my internal medicine colleagues.
Yeah, absolutely. And I think the only, I look back at this case to think about how I would have treated them, today. And I don't know that I would have necessarily done much differently except maybe starting them on a more durable agent from the beginning. But I don't even know that that would have
Yeah.
changed, as you mentioned, because this is all just treating the secondary edema and not the true vein occlusion. And so these are tough and um hopefully one day we have a way to improve perfusion. That would be amazing. We don't really have that, but, currently we're just limited to treating the secondary edema that we see. So let's kind of put it all together and talk about how we integrate stuff into everyday practice. Jorge, I think we talked a lot about these different cases and how we decide when to tighten intervals, obviously, when they have edema and when to safely extend. And you really touched on a really great thing, which is setting realistic expectations and long term planning. I think the one thing we didn't really touch on is I do upfront tell the patients that this is going to be a potentially long-term thing. The nice thing about vein occlusion is that many patients can stop injections, and I tell them that. I want to give them some hope, but I tell them to plan on injections for at least the next 1 to 2 years. Because otherwise at some point they say, "How many injections am I going to have?" And then, I wanna set that expectation from the beginning. So I would really encourage those of you in the audience to do the same. And the other big call that I wanna call out is, again, these we're very used to just treating the retinal condition. We're very used to treating the edema, injecting, and moving on. But please remember their systemic disease. Look and see if they're on anything that could be leading to their vein occlusion. For example, are they on testosterone therapy? Are they on anything that's causing them to be hypercoagulable? Should you do a hypercoagulable workup? Do they have hypertension? Should you check for sleep apnea? Because that's really our responsibility as well for the patient to try to modify whatever systemic issues are contributing to their vein occlusion. So just a really important call out to the listeners out there to not forget about their systemic disease, which is very easy for us to forget about since we're ophthalmologists and so focused on the eye. Jorge, any last pearls for the listeners that you think are really important, especially with regards to vein occlusion?
Yeah, I mean, I'll say, fantastic cases, Priya, and great presentation of the evidence. I think we're very fortunate that we have these second generation anti-VEGFs. I think, as you mentioned, too, the pipeline is flowing quite well. It's not occluded at all. We have longer acting agents potentially coming down the pike here. Interestingly enough, we didn't none of our cases highlighted, but I think glaucoma, I can't emphasize enough how important it is to look for glaucoma in these patients. Obviously, it's a risk factor, and it's something we can really do in the long term to help these patients. as averse as we may be to look at the optic nerve as retina specialists. And then lastly, don't forget that in some of these ischemic patients who you may stop injections on, don't forget the neovascularization, particularly, in CRVO, the more dangerous anterior segment neovascularization is an issue. So, don't just stop injecting and dismiss the patient from your practice. They require some medium-term follow-up to make sure you don't miss that.
Yeah, absolutely. That's a great point. And sometimes for that really ischemic patient, I will just keep them on quarterly injections to help prevent the onset of neovascular glaucoma. Or if they have neovascular glaucoma, they get, quarterly injections long term.
So again, for our audience, this brings us to the end of our program. I hope we were able to show you the evolution of treatment for retinal vein occlusion and how we've evolved from laser treatment to steroid therapy, which still plays a role, but through the advent of first generation anti-VEGF agents to second generation anti-VEGF agents. Really, the importance of tailoring these treatments to your patient. Remember that each patient is an individual, and that beyond the OCT or the fundus exam, uh, treatment really needs to be tailored to these patients, set expectations accordingly. We practice evidence based medicine. We have these second generation agents now that we didn't before that allow us to reduce treatment burden and improve patient adherence. Um, and with that, I'd like to thank you, Priya. Thanks for a fantastic discussion. And I'd like to thank you, the audience, for participating in this activity. And please continue to answer the questions that follow and complete the evaluation.